Hello everyone, my name is Sharon Rojo, and I'm one of the clinical educators here at Healthmark Industries, and your moderator for today's presentation. Healthmark Industries has been supporting its customers for over 50 years, based out of Fraser, Michigan, and continues that support by providing unique educational offerings, clinically relevant, evidence-based, and innovative products. This presentation is part of our commitment in educating our customers, and is not intended to be used as a training guide, but reflects the techniques, approaches, and opinions of the presenters. Your presenters for today are Seth Hendy, Clinical Education Coordinator for Sterile Processing, John Whalen, Clinical Education Coordinator for Endoscopy. We want to note that before using any medical device, please review all the relevant package inserts with particular attention to the indications, warnings, precautions, and the steps for the use of the device. Healthmark would like to welcome you and thank you for all that you are doing to keep our patients safe during this unprecedented time in our history with the coronavirus pandemic, and want to share thoughts to consider when reopening or ramping up your departments. Now let's introduce Seth and John.
Thanks, Sharon. So yes, I'm John Whalen. I'm a nurse and I have over 20 years of endoscopy experience, around 40 years in healthcare. And I'm glad to be part of this webinar today.
Thank you, John. My name is Seth Hendy. I'm Clinical Education Coordinator for Healthmark Industries. I spent 21 years as a SPD personnel, my last few years being the educator for the facility that I worked at. And I too am happy to be able to participate in this webinar today.
Thanks, Seth. So today's topic is safely reopening processing departments, preparations for best outcomes. The objectives for the program today, we're going to discuss considerations for reopening a department that was shut down. We're going to outline considerations for ramping up after reduced activity. And we're going to also talk about Healthmark products that can help in these situations. So we've seen multiple versions of how processing sites have been affected, both short-term and long-term. Many ambulatory surgery and endoscopy centers are closed. Hospitals are seriously limiting the number of procedures and surgeries being performed. So depending on the extent of the shutdown, conversations and questions began pretty early on. What do we do with processing equipment that would be sitting idle? What do we do with processing chemistries? What, if anything, different do we need to do with endoscopes? And what, if any, work was left for staff? So not uncommonly, supplies, especially PPE, were reallocated to the clinical front lines. Supply chain and deliveries for all healthcare items were impacted by worldwide shutdowns. To meet the shortage of N95 masks, processing departments began helping in developing new technologies and/or processes to extend the life of these very critical items. So for especially new processes, this included modifications of existing physical spaces inside processing areas. As we said, this goes well beyond anything we've commonly experienced. For example, endoscopy clinics are very familiar with managing time off for a long holiday weekend, or sterile processing areas may have had standard backup plans to deal with temporary power or utility outages. Those situations, though, involve being closed or limited for a matter of hours or days. With the current pandemic, departments are facing shutdowns for weeks or even months. How long will this current state exist? Well, that uncertainty alone created the need for a measured and deliberate response. So imperative in addressing this are discussions, risk assessments, and implementation plans using a multidisciplinary team. So that means you partnering with infection prevention, safety, facilities, supply chain, and environmental services, as well as management and staff representatives from not only your department, but customer departments as well. So it's going to be those discussions and risk assessments that should then drive any plans for reopening or ramping up. We need to consider the current and possibly now modified state of reprocessing resources, which are staffing, equipment, supplies, and physical spaces. Before we reopen or ramp up, we need to make sure the physical spaces are ready. That'll involve not just cleaning and disinfecting, but likely labeling and signage, similar to how your neighborhood grocery store has now had to clearly identify where people should stand and in what direction they should move. We should ideally test out any changes we make before a true go live, though. Then after reopening or ramping up, we need to ensure we aggressively perform quality control. So what should guide the group work then, the risk assessments and the implementation plans? Over the last few weeks, guidance is now coming from federal agencies, professional societies, and accreditation organizations. This is what most facilities will use to base their reopening or ramp-up practices on. You see on this slide a list of those documents. Please realize, though, that this is an evolving story, so some of these suggestions will likely require future updates. Common points in these listed guidelines include that reopening is based on coordinating with state and local public health officials to evaluate the current incidents and trends for COVID-19 in their area, and that there's adequate resources, especially considering workforce, that you have enough staff, PPE, facility considerations, and supplies. Most imperative is that you keep informed within your institution to know what's expected. Turning it over to Seth now to talk about future evaluating current state.
Thank you, John. Well, I'm going to start, and the first current state that we're going to talk about is equipment. We know that our processing equipment can be affected by use or actually lack of use, and that's sort of what we're going to talk about today. So with our equipment, has any of it been reallocated? Now, I know that that kind of thing can happen with large equipment like sterilizers or washers, but there are other smaller pieces of equipment often that can be moved around in a facility. And was it reallocated or sent to another space to be utilized during your response? The other kind of question that you have to ask yourself is, was your equipment put into some sort of storage? Now, John's going to give an interesting perspective and actually provided some perspective from an endoscopy point of view for storage of endoscopes for one, but endoscopy equipment. And when you put things into short-term storage, into standby modes and things like that, there may be extra steps and time that it takes to bring those back online. And really the last thought that you have to say is, what kind of qualification do I need to do? If this was a full shutdown that you experience and not just a slowdown of your processing, some of this equipment may have been taken completely offline. And if that is true, then there may be operational qualification or performance qualification that needs to be done. I just wanted to give a couple of examples. You know, we talk about instructions for use all the time. We want them for instruments. We want them for our equipment, of course. However, sometimes we need to read the fine print in some of those instructions. And I just want to show here too, from a cart washer, this is from the preventative maintenance piece of the cart washer's IFU. Any reservoir that has not been used for more than 24 hours is automatically drained. To save water, steam, and electricity and chemicals, the washer disinfector can be put in standby mode. So that was somebody saying that it could be put into standby mode and that there was a function for that. What I find a little more interesting, this is a Belamed IFU that's actually taking it to another level and describing what happens if placing something in standby mode isn't done. Microorganisms form in the washing chamber, piping, and pre-wash tank on systems after a prolonged period of disuse. So they recommend that it's requested to perform self-disinfection after expiry of programmed period, which is 24 hours as a standard, following the last programmed cycle. So this is, we talk about it usually for plumbing, and again, John's going to bring this up as it relates to endoscopy, but dead legs. We usually think about that specifically in plumbing and in reconstruction and refurbishment of areas of the hospital. But if you experienced a shutdown or a slowdown, is that something to consider as well? Once we've thought to ourselves, okay, I did have to put my equipment in standby, or I have only been using washer number one because due to decreased volumes of surgery and things like that, my washer was able to keep up. If you have an automatic system, it may have been queuing every load to washer number one, and washers 2 and 3 haven't been used or haven't been used regularly. So with that thought in mind, what are we going to do? Well, of course, we're going to go back to that IFU as I spoke of. You're going to have daily, each cycle, daily and weekly PMs and things that have to be done per the IFU and per guidance. What I do want you to think about, though, is what happens when we talk about additional steps for longer shutdowns, things like priming lines, lines and chamber disinfection, and then calculating your delivery systems, parabolic pumps and the little things that make our water flow and our chemistry flow do require calibration and verification. And that's something that, depending on the length of your shutdown, you may need to perform. We're going to break PQ up, our performance qualification up into three sections, really. I'm going to talk cleaning equipment, then we're going to go for disinfection equipment, and then we're going to talk about sterilization. So, of course, what is our performance? What do we expect out of cleaning equipment? Well, we're going to verify soil removal, spray arm coverage, and function. That's what we expect a piece of cleaning equipment to do, is remove soil. If we have specialized pieces of cleaning equipment, which we often do now in our ultrasonics with irrigation, or in our washers, those special washer racks with manifolds that have irrigation, we're going to want to check to make sure that that is also functioning. We're going to verify cavitation in any ultrasonic machine because that's its higher function. Verify water temp for all things, as that applies to chemistry and function. And then we're going to test water quality. Again, if anything was slowed down, if any water was held in tanks and not used, its quality may have been affected. When we talk about disinfection equipment, we're going to verify minimum recommended concentration is achieved. In all likeliness, if you slowed down or had to stop, your disinfectant has probably had to be purged from your system. But if it was not, or if you slowed down, verifying that MRC is always important. And then we're going to have to verify that disinfectant temperature, especially if it's one of the disinfectants that you can have a shorter time. If at the correct temperature, you can have a shorter disinfection time. And then, of course, our sterilization equipment needs to be running in the way that it normally does, which is pre-vacuum sterilizers have to run your Bowie Dick, and then your biological testing. I just want to look at a few things that help you do that. If I'm trying to verify soil removal, then an object with a test soil trying to clean blood off of stainless steel is what we expect those our washers to do, and running a test that can actually perform that is a good idea to make sure. And this would be, if you're going to especially come back to full strength, we're talking about every washer and every washer rack we need to know that it is ready to go. If you're lucky enough to have a cart washer, then of course the cart washer needs to be checked. If it has an instrument cycle, then you're actually going to go back to that test soil surrogate device. If it does not, and you're just looking for spray arm coverage and temperature, there are simpler tests out there that are able to do those kind of tests. As I mentioned, anything that has irrigation, that irrigation is really there to help remove soil from internal lumens. So simulating a lumen and simulating test soil and verifying that flush function was able to help and clean those devices is something that you need to test. And then, of course, tests for cavitation are out there that are going to let us really know that those transducers are working properly. Water is a big thing with temperature, and then of course disinfectants as well. So a few of the things that you see here are about really just checking water temperature, but the data logger that we're looking at in the top right is all about mapping an entire cycle. So if you really want to make sure that your washer is hitting all its key components, you can actually map the entire cycle. And then in the bottom left, digital thermometers are great because they can check water, they can check disinfectant temperature, they can check all sorts of things. They are a great tool to have and use. And then, of course, I just have a few sterility assurance things listed here where we're talking about type 5. Hopefully everyone's come up to that if you can, because that's really the most stringent challenge that you can give to your sterilizer. A few more things for sterility assurance, as I spoke of. If you're pre-vacuum, if you're not testing your vacuum, then you don't know that you're getting the most that you're supposed to get out of your pre-vacuum sterilizer. Biological testings, and then, of course, marking tapes and things like that show cycles have happened. Here's going to be the biggest thing for you. We say this all the time, and it's absolutely true. If you didn't document it, then it isn't done. And I just wanted to show a quick few images here of a platform that's out there that can actually allow you to input your data and run reports from it and things like that. And so Performance QA is a great way to actually check on temperature, water quality, cleaning efficacy, all of those kind of key components that we talked about. All right, John, can you give us a little perspective from the endoscopy side?
Thanks, Seth. So as Seth was just talking about cleaning and disinfection processes, let's just take a minute to specifically speak to high-level disinfection and endoscope processing. So understandably, amidst all that we're dealing with, people are questioning any and all existing processes. This has run the gamut from who should wear what type of face mask to whether existing processing is effective against coronavirus. So the good news is, for the most part, standard best practices is what is needed. Based on what we know to date, low-level disinfection with appropriate surface wipes is effective against coronavirus. So too is high-level disinfection and sterilization. At this time, no changes in the processing of endoscopes are recommended. This is a time, though, to assess, reinforce, and ensure best practices, from pre-cleaning at point of use through processing to storage and reuse. Some operational considerations have included perchance temporarily limiting the number of reprocessing staff, ensuring complete adherence to PPE, disinfection of automated processing equipment after it's been sitting idle. Likewise, it would really be prudent to consult with infection and prevention in facilities as to whether water lines feeding the reprocessing sinks and AER should be disinfected after sitting idle. So back to evaluating the current state. As well as planning the months ahead, we need to consider the supply chain, the systems, organizations that interact together to design, produce, and deliver the supplies we use every day. This pandemic has really laid bare our weaknesses in the supply chain, most notably for PPE and ventilators. Some of the key assessments then that need to be made by departments and healthcare institutions are noted here. As we reopen or ramp up, which supplies will be in most demand? For example, will it be cardiothoracic and neurosurgical cases first at our institution? If we're an endo facility, is it the interventional cases ahead of all others? Do we have enough supplies to see us through? So critically look at, where do our supplies come from within our institution? Do we store on site and rely on just-in-time delivery through a central process? Is this what we want to keep doing? Where do our supplies originate from the outside of the institution? If the majority of supplies are from the other side of the world, which they have been, and they've been shut down because of COVID-19, what does that mean for if and when we'll receive what we need? Don't assume the lead time for ordering from outside vendors is the same. Whether you are completely closed or work was reduced, an important reassessment is the available supplies. As mentioned previously, not uncommon during this crisis was a reallocation of staff, supplies, and equipment to the clinical front lines. So for PAR restock, as you reopen or ramp up, the usual checks and double checks may have been reduced or missing while you were closed or reduced. Depending on to what extent you're reopening or ramping up, you'll want to prioritize against the projected cases and volumes as we discussed. If supplies like PPE were reallocated, you now need to ensure that you have adequate supply for the work that's restarting in your area. If your department has now taken on the role of reprocessing N95 masks, you're going to need to incorporate those related supplies into your master list. Consumable supplies may have expired during the downtime. So as we mentioned, available space for supplies may be different now also. If new processes were added, this may have taken over existing supply spaces. Do you still have the appropriate and adequate space that you need to store supplies? So in this post-COVID world, is the same way of receiving supplies into the department appropriate? Is the available space then appropriate for whatever new processes? We need to take special note about chemistries as a processing supply. These are our detergents and disinfectants that are used in large quantities. Within any healthcare institution, these are often solely ordered for use by a processing department. The effectiveness of processing relies on both adequate volume and concentration for these. Depending on the shifted priorities during this pandemic, it's going to be critical to assess, did we have enough on hand to restart or ramp up? Did we have to drain the chemistries from automated equipment, so now we need more than usual to even start? Has any of what we use or had expired? Shutdowns have gone on for longer than most expiration timeframes. Were the chemistries all stored appropriately during the down period? PPE has taken on added importance as a result of the pandemic. As we stated before, the reality is that processing steps themselves are unchanged, and we need to all check that we're using best practices. That includes PPE. For anyone providing patient care or processing of reusable devices, it's never been clear that an individual's practice affects whether a patient, a family member, or ourselves are endangered. It's the established best practice that we originally learned in school and in training that'll serve us best. The common questions have been, do we have enough PPE and do we have the right PPE? As PPE overall has been consumed at increased rates by bedside clinicians, it makes sense to reassess your PPE and processing. Go back to the basics to do this. What coverage is needed given the task? For example, decontam versus inspection. What's the exposure risk at each step of the process? Is the physical coverage of the PPE that we have adequate? Are staff effectively protected? It'll be important to reference both against regulatory requirements as well as the national processing standards and guidelines. So let's identify now some PPE solutions from Healthmark, specifically geared to processing areas. Especially as the clinical frontline is using up more and more PPE, having separate processing specific PPE can definitely be advantageous for a department. These include face shields, gloves, gowns, and leg coverings. This gown, the decontam gown, combines efficiency with safety, offers full protection, wraparound 360-degree coverage. The middle zone is manufactured of a liquid impervious material, and it includes preventing strike-through of detergent solutions and other cleaning solutions, even when physically leaning against sinks or other cleaning baths as we commonly do. There's less waste as these are reusable. They would be used by a staff member, single use, one per day. Now we talk about gloves. Starting lower left on the slide, we have the ultra-long decontam glove. These are single-use, powder-free nitrile, ultra-long gloves, and they were developed for improved protection for staff. They offer excellent tactile sensitivity with full textured service for improved grip. At the top of the slide, we show the sleeve gloves. They don't slide down, they provide the highest level of protection. These are latex-free and they're one-day use. They're sold in pairs and they're resistant to a broad range of hazardous chemicals. On the lower right, you see the standard length decontam glove. These are thicker, they're 15 mil, powder-free, and latex. As evidence to their protection from hazardous substances, they're certified for use with chemotherapy. Additional options, we offer 3 styles of face shields. We have the no drape, the extra wide drape, and the extra long drape. This is a full face shield which provides the best blast protection against exposures. There's a 13-inch fluid barrier which extends below the full face shield. The barrier fabric itself tucks into a sterile gown, a processing gown, providing additional protection. Additionally, we offer liquid-resistant bootlegs and shoe covers and jumpsuits. The disposable mid-thigh protective leggings are slip-resistant. There's a mid-thigh elastic hem which holds the bootleg comfortably in place. The non-skid disposable jumpsuit you see is one size fits all, and it's made of impermeable polyethylene. During this COVID-19 pandemic, we've seen increased interest in our Kool-Aids to help staff keep cool under the layers of PPE that need to be worn. We've had places reach out that aren't even processing areas for these. The way these work, you simply submerge the headgear or the neckband in cold water for 2 to 3 minutes. They're made with 100% cool mesh. They're lightweight, durable. They provide 3 to 5 hours of cooling relief after soaking. They're available in a wide variety of colors and they can be personalized. For additional heat relief, you can pair one of these with our Kool-Aid vests, which utilize coal packs for core body cooling. They're lightweight, easy to activate, and durable. Speaking of staffing, let's go back to Seth to discuss staffing considerations.
Thank you, John. And of course, keeping your staff comfortable with long wear of PPE, which is what we're seeing happening. We've all seen pictures of people with bruises from having to wear masks and face coverings and goggles for so long. So, helping anyone be comfortable in their PPE in this time is going to go a long way. I'm going to talk about staffing a little more generally as we do this. There's going to be several factors that you're going to need to take into account when you transition back to your full case volumes, which is where we're all trying to get to. At first, it's going to be what are your current and what are your projected. You may start on a smaller scale. We're going to see more surgeries become available for people to perform. Anything that was put off is going to get some priority, I'm sure. But eventually those full elective surgeries are going to come back. And so this is really probably going to be an ongoing thought. What are we doing now? What are we doing in the future? And what are we doing in the far future? And then, of course, as you take those case volumes into consideration, then the supplies required and their availability becomes an issue. So all of those things that John just listed are supplies that you are going to need. And depending on your volume and that increase, you may need more now than you have. You may need more in the future. And the real question is, how robust is your supply chain to be able to even get it? And if you can't, that has to be considered by your facility as to whether or not that they're ready to ramp up or to bring this back. Space requirements for distancing, and we're going to talk about some good options for that, as John mentioned. Because you're finding that if your state is opening back up, as they say, there are still guidelines for social distancing that have to be adhered to. And then really a factor that we all must consider is, are your staff going to be available? I know that many people want to get back to work, but if you have someone at home that you're taking care of who's elderly or childcare or things like that, that's a concern for one. For two, people are still fighting illness. And so just your actual availability of staff numbers. And then, of course, serological testing is going to be a big thing. Are we going to be able to say who can come back very safely? We would like to think, because they've already been exposed and have gotten over it. A few more things to think about is, as an educator, staff competence is close to my heart. It always has been. It was a large undertaking at the facility that I worked at. It took about a third of my year was getting every staff member in the CS department competent. So there's just a few things to consider when you're doing this, and are they up to date? So that's always going to be a big thing. It was always a struggle. There's a few basic ones that you really have to think about in this way. Are your basic competencies current, such as hand washing? That's such a large recommendation now about safety, about personal safety, is personal hygiene. And so if everyone has not had a hand washing demonstrated competency, that's something you should definitely consider. Donning and doffing PPE. We do so much work trying to protect ourselves, and if PPE is not applied, and so if you go out and get it, that's great, but if you don't apply it or remove it properly, then you're actually taking all that work to acquire that PPE and have it there and not get the benefit of it. And then regular device or equipment operation and processing. So is there anything that you just aren't up to date with and your staff isn't ready to use? Then, of course, we're going to talk about new competencies, because there are going to be things that have come up or have changed because of COVID-19. So if you have any new policies put in place, everyone has to be competent with those too. N95s, not just about reprocessing, although, of course, that's a thing. An N95 has a fit and should be fit tested. So a person needs to be acutely aware of how they handle that mask, how they apply it to their face, and that they have been and are able to be fit tested. Just an FYI, beards are not so great with an N95 mask, and so this is something that has to be considered. Are there new devices or equipment operations that you need to take into account? Now we are talking about reprocessing masks. Everyone has to understand what your machine's capability is, and then what your facility's policy is for chain of custody for masks, if they're going back to the same person that was wearing them, all things like that. And I'm aware of a few people that are not full ventilators, but are being expected to process ventilator components. And that's something that may be very new to you and to your department. New routines for interacting with customers also are something that should be verified. Pickups, drop-offs, and rounding. If you are, as most of us are, and as it was in the facility that I worked at, if you are responsible for going out and doing some rounding, I guarantee there is a new procedure for that to be done well and safely, and everyone has to know. And then the last thing I want to say is if you're down, and we've seen this in education with sort of a boom for education, because some people are saying, well, my volumes are low, but I have people here. Is this an opportunity to catch up? And as a person who had to work all those competencies for that many years, I would take any opportunity that I could to catch up. So what about separation within the department? Okay, we are getting people back, and when they come back into the department, if you had been working at lower volumes, maybe you didn't have as many people. Now, as we come back up to a busy department, are we going to be able to do some of the things that we need to do? Will it be necessary to maintain social distancing in your department in certain places? I'm absolutely sure that that is going to be. Consideration should be given to whether the department will be able to have full staff all at once. So that's when we're thinking about this. Am I going to be able to, if I'm told to maintain 6 feet of social distancing, am I going to be able to fully staff my department due to just sheer square footage? Additional things to think about is creating workflow patterns to keep staff separate. I love that my local grocery store has one-way aisles, because that actually gives us a structure to help us maintain distance. Will you be designated workstations and spaces that should remain empty or unused to acquire the distance that you need? You will increase the volume of masks and gloves in your department, because that is most likely still going to be something that in the group we should still be wearing face masks. And so not only, as John mentioned, them really as a decontam and a processing component, will you need them on the clean side as well? And this is something that's interesting, and it's an idea that we're talking about. If you do that serologic testing and you find out that you have people with the antibody, will you be reassigning tasks and higher risk tasks to people who are at a less chance of being infected? This is just an interesting thing to me, because I thought about two things. What do I already have? What am I already using maybe in my department? Because it was just a good idea that now is coming to the forefront. And so as you see here, we've had for a long time keyboard covers, which you should have. It makes disinfecting them much easier. If you don't have a keyboard cover, I hate to think about what's in there. So keyboard covers, cell phone covers, tablet covers, those have been a thing that actually had a place in CS before now, and really should be like, wow, these are very, very helpful in dealing with COVID-19. But then on the right side of the screen here, something I had never thought of before, being put in place in my department, which was a screen, like at the grocery store or your pharmacy. Is that something that you would now put in your window where you have customer interactions, and you're able to give things out with a shield in front of your the window into your department? Now we're going to talk about space. We evaluated our equipment, we did our staff. Now let's talk about the current state for space. It really does feel sometimes that we're already separate, doesn't it? We already feel a little separated because we're in a semi-restricted or restricted area. Not everyone can get in to our processing departments, so it makes us feel like there's some space. However, most processing departments do have some sort of pickup and distribution of products with the departments that they serve. So it doesn't mean that we have total separation. And when you want to adhere to distancing guidelines, that may require adjustments to those routines. Are there going to be areas that need to be designated as pickup and drop-off locations so that you can limit contact? Will you say, actually, we're not going to have anyone come to our front window, we've allocated a different spot for that? procedures for requesting supplies ahead so that they can have contactless pickup. That's another thing. Instead of coming and ringing the doorbell, which we all had, right, and saying that there's someone here, will you be instituting a process where you ask them to call ahead and supplies can be set out and that transaction can be contactless. And then in areas where lines must be formed, we can give guidance on proper distancing to help people comply. It's a hard thought, it really is. And so we need visual aids for that. How will your facility create physical space when it's needed? Well, it's going to come in the form of a sign. Now, I wanted to show you some signs that we're all used to because they informed and they help keep us safe, right? Be careful, don't get hit by the door. Please be careful, don't slip on the wet floor. Those signs have been around for a long time, trying to help us be safe. But we're starting to see signs now that I kind of never thought I would see. Signs on a floor that said, thank you for practicing social distancing, or calling out that social distancing is 6 feet. So that's really a sign of our times. It's always been something that we need, and now we've got them for very specific reasons. You're going to see them up in patient and visitor and reception areas, right? These spaces where people still need to congregate at some level. We have to help people understand distance and being able to keep their distance. We want to designate workstations and spaces that should remain empty. So if you've got two stations that are very close and you want to say, we're going to work at this one and we're not going to work at this one, a sign can help out. And then illustrate new traffic patterns. So if you pick supplies like most of us do, designating one-way workflow patterns might come in very handy, helping people maintain their distance. It's just another form of sign, right? These are actually wall signs that can be put up. Wall signs next to sinks to really talk about hand washing. I do find it interesting how many times that was mentioned. Oh my goodness, if they tell me to wash my hands one more time. Well, you know, again, as an educator who had to help people and make sure that they were washing their hands correctly and have that conversation, we've talked about it often because compliance with it has been difficult. It's been difficult throughout the years, and it still is. And then other things like telling people where they are required to wear gloves and face protection. And then are we having quarantined areas? That is very likely a possibility, and being able to designate a quarantine area. Custom labels are kind of my favorite because now I can say practically anything that I want. I can, whatever message I want to display, I'm going to be able to do. So traffic flow patterns for visitors, temperature check stations, that's not a sign that we would have thought that we needed, but since it's in many places, if you would like to have a sign for that, it's something that can be made. And then of course, mask collection. Again, not a sign that you're going to find in normal production, now something that we need maybe to be able to display. And then, of course, floor signs. You know, there's always going to be applications for being able for needing to put things down on the floor where people are going to see them. And again, those things that we expect to see in this day and age, talking about social distancing, showing a quarantine area. It was very interesting. I like this sign. I had a problem with my water heater and had to have someone come to my house during this time. And we did that thing where he reached for my hand and I reached for his hand, and we both figured out that we shouldn't do that. So those little reminders are things that we need, and an array of signs can help you do that and keep people safe and thinking about the right thing. Now, John is going to take over again.
Thank you, Seth. So Seth just spoke to physical space considerations. We need to also consider the impact on transport and storage. It's going to be important to critically consider how items are transported and stored now that we're ever more aware of possible transmission to and from physical surfaces. So as you see, some of the questions posed here need to be asked. Does closed transport and related signage need to look different? Did you take on other work, such as N95 mask processing? What about post-HLD items like flexible endoscopes and TEE probes? How visible is their patient-ready status? Do we need to improve the protection in storage spaces? We've already seen several examples how existing Healthmark products have proven useful as staff and facilities evaluate their post-COVID processes. Additionally, we've had examples where A health system ordered a large number of SST trays for use in transporting N95 masks to an off-site sterilization facility. Another customer expressed interest in the scope sleeves to consider as additional protection for endoscopes left in extended storage. So we mentioned our SST trays. This is a foundational Healthmark product. And then covered SST containers in closed carts afford double protection during transporting. The carts are constructed of one-piece double-wall plastic. They're completely cart washable. Recently, we had a customer using our transport trolley cart, as you see here in the middle. It was originally designed for flexible endoscope transport, but they wanted to use it to transport N95 masks between point of use and reprocessing. Again, with increased awareness and scrutiny about surface and environmental contamination risk, our cart covers, like you see in the middle, reusable as well as disposable, offer a literal layer of protection for our valuable devices and equipment resources. So visual process identification is foundational to any quality control. Our labels provide that differentiation and identification for both clean and contaminated containers and carts. Other examples recently from the pandemic, with the influx of ventilator usage, a customer is using our tray identification tags to track how many times the ventilator temperature probes have been sterilized. And customers have been using our self-looping instrument tray labels to label N95 masks with the user's name and information. So let's consider quality control further, how it relates to the current state. You see it broken down here by people, processes, equipment, and devices. For people, communication with staff and customers is so critical. As a manager, you can invent the best plan, but unless you communicate effectively and often with staff, it can easily fail. Rounding verification, what does that mean? It means go see. Whenever processes change, similar to medication, you have intended and unintended side effects. Go see to make sure that processes are happening the way you intended. Always have documentation at QC, not just for proof or a receipt, but to make sure evaluation happens over a period of time and you can compare that. The new norm in these post-COVID days includes increased attention to surface and space disinfection. Make that part of your regular quality control. Make sure it's integral to the practices moving forward. So equipment PMs and disinfection cycles. If you were closed or running at less capacity, make sure these didn't get missed. And make sure disinfection cycles happen before you reopen. Don't forget about the filters and pre-filters. For example, for AERs, there's pre-AER filters and there's in-machine filters. They may require changing sooner than normal because of plumbing sitting idle. Make sure to follow processing equipment manufacturers' instructions for use on how to take equipment out of long-term downtime. They often require at least disinfection after extended downtime. And then for devices, make sure your devices are truly patient-ready before you reopen or ramp up. Make sure that packaging or storage hasn't been breached. For endoscopes in storage, did the shutdown create a situation where the scopes have now exceeded your institution's hang time policy? Make sure you've reinstituted best practices for inspection, cleaning verification, and surveillance as per your policies. As shown here, Healthmark offers several options for quality control to inspect and verify cleaning processes. Reopening or ramping up is an opportunity to institute quality control measures, even if they didn't exist before. Post-COVID, we're painfully aware of the need to have solid processes in place that follow manufacturers' instructions for use and best practice standards and guidelines. We won't know how we're doing unless we measure. That's where quality control comes in. Moving left to right along the top of the screen, we see HydroCheck. It's a single-use product designed for detecting residual moisture in channels. Channel check is one that many are familiar with. It allows testing virtually any lumened instrument for residual organic soil. It's a 3-in-1 test. It tests for blood, protein, and carbohydrate. For the flexible endoscope sampling kit, Healthmark Industries and Nelson Laboratories joined together to create this. It allows bacterial surveillance testing for flexible endoscopes. Sample that is taken by the facility is sent to Nelson Labs for independent testing, and they are able to determine the presence of any microorganisms. If there are any present, they are identified and quantified. On the top right of the screen, you see the Now test. It's another post-processing surveillance option. It's a simple 12-hour test for gram-negative bacteria. Why this is important, it can be very helpful in limiting the downtime a scope is out of service awaiting surveillance test results. Lower left, back to cleaning verification. The ProCheck semi-quantitative protein test, it's a rapid and easy to use and interpret test that checks for residual protein on any item after post-procedure cleaning prior to further processing. Enhanced visual inspection includes the use of borescopes. Healthmark offers several of these. They provide light, vision, magnification, and the option for documentation in hard-to-see crevices, channels, and lumens in instruments that otherwise you wouldn't know exist with the unaided eye. Finally, on the lower right, you see the Aqua Test. It's a 3-in-1 water quality test strip. It's used to test water used in the cleaning processes. Results are available very quickly within 30 seconds for pH, alkalinity, and hardness. As we said, these represent several options for quality control to inspect and verify the cleaning processes. With quality control in mind, I once again turn it over to Seth for wrap-up.
Thank you, John. We, of course, can't ask every question, but as John and I were putting this program together, we were thinking, can we get a conversation started? If this is going to happen, which we know that it is, what can we do? What can we start to think of? So I'm just going to end with a few things. You know, critical thinking is huge in hospitals in general, but in processing departments, you're presented with a challenge and you have to figure out what's your best action. So to kind of close this off with some of the things, you know, these are some of the questions that we're asking ourselves and you should be asking yourself and critically thinking about and risk assessing what you're going to do. So is your staff appropriately educated regarding the cleaning IFU of instruments, old and new? Right? Are we ready for that? Do you have the proper PPE to feel like they're protected? That's, of course, critical right now, as we talked about. Do they have adequate supplies when needed to follow the manufacturer's IFU, brushes, light and magnification, surveillance testing? With just-in-time ordering as something that we mentioned, are you ready now? Does your instrument tracking system allow you to build in hard stops for quality? Or do you have a way to document that you're doing it? And if you do, if it does, are you using it? And then what is your process for vetting new technologies associated with equipment as part of the process? We could not ask all the questions there. You'll have individual questions for sure, but just a few things to start that conversation and to start you thinking. And in conclusion, to really wrap this up, let's kind of bring it all the way around. Pre-COVID-19, we were in such a hurried pace, turning over instruments, endoscopes, you name it. Ordering stock was just in time because at that point, that seemed like the best way to have inventory, but keep costs down, trying to keep our staff educated and motivated. So as we prepare our department to restart, let's take the opportunity to think about some new things and to potentially learn from the environment that we're in. So if we can map out a journey to success, partner with infection control, vendors, risk management, the OR, you know, get your key stakeholders together and really make sure there's a good cohesive plan to move forward and that some of these pitfalls that we found that, you know, maybe need to be adjusted and done differently. The restart after COVID-19 will bring new opportunities and lessons learned. So taking time to think about those and think about not running into those same obstacles in the future will go a long way. And being present and understanding we are all in this together for the same reason, which is really the patient I know that that's lost sometimes when you're in a processing department and you may never see a patient except in the cafeteria, but really what we do has that effect, and that's what we're all trying to do is provide best patient outcomes. So let's move forward with positive energy and always by doing the right thing.
Thank you, Seth and John, for giving us steps and considerations and products that supplement reopening or ramping up your department. We want to welcome you to, please visit our website for educational offerings as well as product information. Thank you, everyone, for choosing Healthmark Industries and your support in education and products. Thank you.